Hello, everyone, and welcome to today's live broadcast, Alinity HQ Sigma Metrics, presented by Sten Westgard, Director of Client Services and Technology, Westgard Quality Control. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Abbott Laboratories. For more information on our sponsor, please visit corelaboratory.abbott. Now let's get started. I would like to remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. If you have any trouble seeing or hearing the presentation, just use that Ask a Question box and let us know you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab and follow the process to obtain your credits. I'd now like to introduce today's presenter, Sten Westgard. Sten Westgard is the Director of Client Services and Technology for Westgard Quality Control. He earned his MS degree in computer science from Pace University in New York. For more than 20 years, Sten has managed the Westgard website, course portal, blog, creating and administering online training, as well as editing and writing hundreds of reports, essays, and applications on quality control, method validation, Six Sigma risk management, and other laboratory management topics. For a complete biography on Sten, please visit the Biography tab. Sten, you may now begin your presentation.
Thank you very much, Christy, for that kind introduction, and welcome all of you to this webinar on designing quality control for hematology instrumentation that has to do with Sigma metrics. So we're going to be covering some basic things and also some advanced things, some basic QC challenges that have been with us since we started running QC for hematology, as well as some of the latest tools and techniques for optimizing how we run that QC. And I want to start with a disclosure statement. I just want to be very open. Abbott Diagnostics is compensating me for my time, and we couldn't have this webinar today without their support. There is, however, a much more important disclosure that I do need to make, and that is particularly important when you're listening to this as a webinar and you can't see me. If you didn't see me and you didn't know any better, you might be thinking that I'm the Westgard, the one who came up with the Westgard rules, but actually I am really only a Westgard. I am the son of James Westgard. James Westgard, of course, is the author of the Westgard rules and really has spent more than half a century working in quality control for laboratories. I am the junior employee. I've been only doing this for about a quarter of a century. When I'm not doing webinars or lectures or workshops or any kind of training, we're running the Westgard website. So we have a number of different resources, and a good deal of it is free. This will be a good resource for you following the webinar to explore some of the things that we'll talk about briefly in this broadcast. So our first website is our main flagship. Westgard.com has more than 65,000 laboratory professional members and more than 600 different articles on Westgard rules and QC and all kinds of topics related to quality and analytical performance. In the center, you see our course portal, which is where we do structured training. If you need continuing education or contact hours, we have courses in Westgard rules and QC and Sigma metrics. And then in the lower right, you see what we call a blog. This is where we handle shorter articles, comments, things about what's going on in the news, and probably most importantly of all, we handle our questions and answers there. So as you can imagine, there are a lot of questions coming in. We like to answer them so that we not only help the lab that has the courage to ask for help, but also dozens of other labs that really are facing the same problems but may not realize that they're not alone. All of this material on westgard.com and the blog, that's all free. So there's a lot of free resources for you, and we'll be going through now some of the specific tools that are good for hematology. But before we delve into those, I want to step back and really focus us on why we're talking about quality still, and why we must continue to talk about quality. We cannot just assume that because a manufacturer has a good marketing campaign and they assert that they have great quality, that therefore we don't have to do our jobs and we have no professional responsibility. What you see in front of you, of course, is a picture of the now infamous Theranos and its founder, Elizabeth Holmes, a company that took in almost $1 billion of funding and promptly destroyed all of it because at heart it was an instrument that had no quality. They could not produce reliable results. And one of the people who helped bring this fraud down was a medical technologist. Her name was Erica Chung. You can see her in this documentary from HBO, and I had the pleasure of communicating with her. She was saying that one of the reasons why she felt bad about what her company was doing is she was looking at the Westgard rules, she was learning about QC, and she quickly realized that what was happening at this company was not following the basic of QC principles and practices. They weren't implementing Westgard rules, and as the quote says, they were very far from Six Sigma laboratory principles. And based on understanding that gave Erica the confidence and really the mission to say, I can't let these kinds of results go out the door. I have to protect patients. And she helped blow the whistle, and then the inspectors came in and shut that laboratory down, which ultimately led to that company ceasing to exist, going completely bankrupt. And that's one of the things that we can get out of proper QC and these Six Sigma principles. They can tell us when we're not doing our job and when we have, in particular, an instrument that is not providing the quality that's necessary for patient care. In addition to talking about the problems of QC, specifically in hematology, we're going to talk also about Westgard rules and Six Sigma, and even a more advanced topic, the optimization of QC frequency. And this is really the next generation of how we're going to do QC, not just in hematology, but really on any instrument. We're going to figure out how many Westgard rules are necessary, how good is this assay on the Six Sigma scale, and when we know that sigma metric, it will change the rules, it will change the controls we have to run, and it will change how often we have to run those controls. And we'll look at a couple examples of real-world instruments and performance and apply those tools so you can see how this will work for your hematology tests. So let's review a little bit about our problems specifically in hematology. What you see is a paper from 2010, so this is a little bit of a while back, but here is the sort of paradox that we find ourselves in hematology, and that people assume the instruments themselves are quite good, but then there's a high amount of variability in how QC is practiced, and a lot of practices that are not considered ideal. So in some recent surveys, we've seen a 12-fold variation in QC. Some recent surveys have shown that here in the U.S., some of the leading academic medical centers, some labs are doing QC once a day, and other labs are doing QC 12 times a day. A 12-fold difference. That's telling us that the practice of QC is not very standardized, even in some of the best institutions in America. And that means we really need to bring better tools and assessments into how we practice our QC. one of the frequently asked questions about hematology QC is whether they can just rely on the manufacturer's information. And if the manufacturer says, this is the mean and this is the standard deviation, you don't have to figure it out yourself. You just use their information. If we look at the global quality standard of ISO 15189, it says very clearly you have to design internal QC systems that verify the attainment of the intended quality results, and that language implies that you're doing your own calculations. You're not going to simply rely on the manufacturer. Also, we're not supposed to rely just on manufacturer-provided controls. Again, the global standard for quality in its most recent edition recommends that third-party independent controls should be used to monitor your processes. If the manufacturer has its own control, they're not considered as reliable. It's too often known, and many of you know the anecdotal evidence, that manufacturer controls and ranges can sometimes be tweaked or adjusted. They might synchronize a control to a new reagent lot, and you lose the objective independence, the ability to truly monitor what's going on with that instrument. You may miss some of your errors. And with hematology, it's very tempting to just use the manufacturer's control range. But the CLSI guideline, which states the best practices for hematology, QA and QC, it says that the laboratory must establish its own expected mean and QC values of recovered control values. And it specifically calls out the published manufacturer ranges. They are too broad for effective QC. If you rely on someone else's range, the manufacturer ranges are typically built on many, many labs, and so there's more variation, and those ranges are much bigger. And if you use them, you may feel like everything's in control, but really what's happening is there may be errors occurring that are going through that very broad range and going out and reaching patients. You are being blinded to them because you've set up your chart so that you don't see those important errors. You're not catching them. The other thing that we have with QC for hematology, and this isn't in particular something that because of the lifespan of hematology controls, it comes up that labs feel the control doesn't last long enough to really establish their own mean and standard deviation. And if you collect the minimum recommendation of 20 data points, you may, if you're only running QC once a day, then that's almost a month, and you may only have one more month or at most 2 more months on that control lot. So it feels like it's a lot of extra effort to keep up with establishing your own mean and your own variation. And there are a couple different solutions. Some are better than others. Probably the least effort is overlap your controls between the new lot and the old lot by a short period of time, making multiple measurements. You'll be able to establish a new mean. You'll get a new SD. The downside is that over a short period of time, that SD is not as reliable. It probably will be overly optimistic. So these other solutions are what we would prefer. The second one is to use 8 or more overlapped values to establish your new mean. And with just a few number of measurements, you can effectively establish the new mean. It's the new standard deviation that really needs more data. And so while you're waiting to collect enough data for the new standard deviation, you could use the old CV from the previous lot of controls, and then you multiply that by the new mean, and that will give you a temporary ST. So you'll have a temporary ST to cover sort of the first 20 data points while you're trying to collect enough information to establish the real standard deviation of that new control lot. So you have some sort of temporary crutch to lean on while you're developing more information. The third solution, and this is one that takes into account much more data and over a longer period of time, is to use multiple lots. So you have a cumulative mean, you have a cumulative SD, you put together 3 to 6 months worth of performance data. Now that relies on an assumption that from control lot to control lot, there's a lot of stability and consistent performance. If you find the controls do not have that lot to lot, there's big jumps and big changes in SD, that's not going to be a good solution. But solution 3 is really the one that we would like laboratories to adopt for hematology QC. And now we're ready to look at our Six Sigma concepts. This is the solution to all of those previous problems that we were just talking about. Six Sigma is a universally accepted way to benchmark your quality. And it came out of manufacturing and industry. It's also used in lots of other phases of healthcare. We're particularly lucky in laboratories to be able to take advantage of Six Sigma because we collect all the data that is necessary to do a Sigma metric. And the idea with Six Sigma is you're going to convert your measurement through a calculation into something on the scale from 0 to 6. And when you're at 6 Sigma, you have less than 4 defects per million reportable results. So it's really almost defect-free. And that means you're going to have clinicians who are very confident in the analytical quality. They don't feel like they need to run the test over and over to figure out what's going on with the patient. Your first result is going to be the right result. And at Six Sigma, when the originators of this technique achieved it, so we go back several decades to companies like General Electric and Motorola, when they found they were at Six Sigma, they had extremely happy customers because they were getting the right process, the right output, and they were getting it reliably, and they had good confidence. So it's great on the customer side, but internally they also found, well, there's a lot less effort we have to make. We're not making mistakes. We're not having to come up with workarounds. We're not having to do work over and over again. So it was also very efficient and very profitable for them. Now, GE and Motorola, they found that 3 Sigma was about the floor on performance for them. Below 3 Sigma, which is something more than about 67,000 defects per million reportable results, that becomes too unstable. There's too many errors. You're going to spend too much of your time having to fix those errors and come up with workarounds and do extra effort. It becomes too expensive to keep that process as a routine part of your business. And within healthcare, if we look at our laboratory, below 3 Sigma is really where we start to see labs and tests that are going to be repeating their controls frequently and recalibrating a lot of the time and troubleshooting multiple times in a month and calling up their technical support. And really, it's just a lot of extra activity, a lot of burden that a laboratory has to shoulder when they have a test that is so low in quality. There are a lot of different quality requirements that are available for hematology, and this is the first part of establishing a Sigma metric, is to really establish what is the performance required by the method. What is the quality goal, if you will? And we have CLIA in the United States as having set a bunch of allowable total errors. In Germany, there's the Rillibach. There is a biological variation database that was started by Carmen Ricos in Spain, and that database terminated in about 2014, but that's probably the most popular global set of quality requirements for hematology. There's also from the Spanish proficiency testing programs a consensus on the minimum quality. And then most recently this year, the European Federation of Laboratory Medicine, or EFLM, they have created this UBVAS, which is, again, based on biological variation, but more recent information. And they have also set that up as a database online. So we have at least 5 different sources of quality goals for some of our tests, and you'll notice they don't agree. Some of them disagree quite a bit. Sometimes there's a goal from CLIA, which is twice as large as a goal from UBVAS. So among them, we try and make some choices, and typically for labs, we will ask them for the main parameters, look at the CLIA requirements. For another, for the MCV, look at the Spanish consensus. And then there are other sort of the differential counts where most of the major EQA and proficiency testing, they do not set a specific goal, so you have to look at the biologic variation. And the biologic variation goals from RECOS are the ones that are, at the moment, the most practical goals to achieve. The new goals that came out this year, we have found to be very difficult for laboratories and instruments around the world. What you see here is a set of performance measurements. This is bias versus allowable bias for 4 different instruments. And I don't want to call out specific instrument types. I'm just going to say some of them are major instruments from major diagnostic providers, and others are smaller instruments from smaller companies that you may never heard of. But when we look at the desirable bias, which can come out of that European Federation of Lab Medicine set of specifications, how many of these tests can actually achieve the desirable bias, having below that particular level of bias? Well, across the board, these 4 instruments that we looked at, more than half of all the performance in these tests cannot meet those bias goals. More than half of the numbers being reported at different control levels on different parameters are failing the desirable bias test. And if you see a goal that has come out, and in the worst case, 3/4 of the performance of one instrument cannot hit that desirable bias, you begin to think that set of goals may be too tight for today's market. Maybe in a marketplace in the future, maybe in the next generation of instruments from some 5-10 years from now, maybe they will have a chance to hit these new goals, but right now they appear to be very difficult to achieve. And it's also true for the imprecision goals. So the bias goals, more than half of them couldn't hit the bias goals. There's quite a big spread of performance in the precision goals. So some instruments, more than 80% of their performance cannot hit the precision goals. Another instrument, more than half of it cannot fit the imprecision goals. So again, those particular goals may not be appropriate for today's performance, for today's instrumentation and their generation of methods. All of these goals we've listed on the Westgard website, what we call a consolidated hematology set of goals. You see that screenshot is showing you the different sources of allowable total errors. And one of the things that we have found is that there's no one set of goals, so even CLIA doesn't give you enough goals to cover all the different parameters, so you have to look at not just CLIA, but some other goals. And we've tried to identify which goals we recommend as most practical without being too easy. We don't want to make a goal that everybody can hit, because that probably means it's too easy, that it's too wide. So we try and find a median goal, something that is challenging, that helps move the industry forward. Once we've settled on the right goal, we've selected these performance specifications, essentially you have to think of that as setting a target. By figuring out that allowable total error, wherever it happens to come from, now you have a target to hit with your assay performance. Whether you hit that target, well, that's when we start to measure our own performance. And this is where we already have the data at hand. We've been collecting data on our analytical performance since we opened the doors of our laboratory. And what we specifically want to collect is imprecision or CV data, as well as inaccuracy or bias data. And while typically we may be running 2 or 3 levels of controls, we might want to focus on particular medical decision levels and focus on the sigmametrics at one particular level of a test rather than all 3 levels. We put all these 3 variables together, the allowable total error and the bias and the CV, in our sigmametric equation. So this is our first tool, and it helps us benchmark the quality of our assay on the sigmametric scale. And what you do is you take the allowable total error, you subtract the absolute value of the bias, and then you divide by the CV. It's your performance goal minus your inaccuracy divided by your imprecision. And then the graphic below that is really to give you a visual sense of how the equation works. In the center of that graphic, you see the true value. That's the answer we're supposed to be getting. But of course, we don't always get that answer. We get a distribution. We get a bell curve around that true value. And then at either side of that true value, there's an allowable total error. And that zone from allowable total error on the left hand to the right hand, that's the amount of error we could make with our measurement without changing the diagnosis, without changing how the patient is treated. You can keep within your allowable total error. You won't get the exact answer, but you'll get an answer that is close enough that the clinician makes the right diagnosis, the patient gets the right treatment. So we want to keep all of our values, if possible, within that space. The data that we get from the bias and CV tells us how much of our curve is actually in that space. The bias will tell us how far away we've shifted from the true value, and the CV will tell us the spread of that curve, how wide the curve goes, how much dispersion there is in the results. And when you combine that bias and CV, you may see, as we do on the right hand of this graphic, there's a part of the tail that goes outside the allowable total error. We have some results exceeding the allowable total error, and what that indicates is that area under the curve, those are the defective results. They may be false positives, they may be false negatives. They're results that are clinically significantly wrong. So having introduced that tool, let's walk through how that tool is working. So we'll take an example, 3 levels of a hemoglobin method. And if we want to know the sigma of hemoglobin, we need our 3 numbers. We need the allowable total error, which CLIA directly regulates, so we know we have to be good within 7% of the true value. And in this particular data example, we have been running 3 levels of control. So we have imprecisions at different levels, low and high, and somewhere maybe the normal, all of them less than 1%. And then through a comparison of method study, we've also calculated out the bias. So we have bias using a regression equation at the same 3 levels where we've figured out our imprecision. So we can actually do a sigmametric at each level that we're running a control. And you can see at the first level, you have 7 minus the bias of 0.4, and you divide that by 0.5. We actually have a better than 6 sigma performance. And this is actually at the, I believe, the high end of the range for that test. The next performance is at the low end of the range. It's 7 minus the bias of 3.1 divided by an imprecision of less than 1, or about 0.8. Again, that's a good good result, we have a 5 sigma performance at that low end. And then in the middle, we have 7 minus the bias of 1.4 divided by an imprecision of 0.6. It's better than 6 sigma at the upper end of the range. So here you see at the extreme ends of the range, at the normal and the high end, we have better than 6 sigma performance. At the lower end, we have 5 sigma performance. And you may want to decide how to treat this assay now. Do you treat it as a 6 sigma assay? Do you treat it as a 5 sigma assay? Do you average all of that and say it's somewhere between 5 and 6 sigma? And it's really up to you how you want to do that. However, on hemoglobin, you want to also figure out what is the critical decision level for hemoglobin and use the metric that you're finding at around that level as the way you're going to treat the hemoglobin method. Oh, and then there's the data. If you're just looking at how things were calculated, that's the data set that we have for that example. Once you've calculated it, you have the sigma metric for a particular test, but you may want to actually visualize it. Some of us don't like to look at any more numbers than we have to, and to introduce a whole new set of spreadsheets and tables may seem like more work on an already overburdened workload. So we do try and simplify these things. What we have now is a method decision chart, and this gives you a visual way to figure out the sigma metric of your method. And in fact, you can adapt this so that you can look at all the methods, all the levels of your entire hematology instrument, and on one graph, you can figure out how you're doing. So it's a visual assessment rather than having to do all the calculations. And what you do is you take the imprecision, and that becomes your x-axis. You take the bias, that becomes your y-axis. And then you're going to plot your imprecision and your bias as x and y coordinates. So we have a tool called the method decision chart. And the method decision chart helps you plot and visualize the performance of your analytical quality. You don't have to do as many calculations. You can look at really an entire instrument worth of performance in a single glance. Along the x-axis, you're going to plot your imprecision. Along the y-axis, you're going to plot your bias. So your CV and your bias for each of your control points, those are your x and y coordinates. And the way this graph works, you have diagonal lines that divide the graph up into sigma zones. Near the graph's origin, you have world-class quality. That's the 6 sigma and better performance. If you have about 5 sigma, that's considered excellent performance. 4 sigma is considered good performance. 3 sigma, as we said earlier, is the minimum or the marginal level of quality. 2 sigma is poor. Less than 2 sigma is unacceptable. And if you will, you can consider this chart similar to a bullseye, similar to a target. What you want is to have your data as close to the bullseye as possible. The closer you get, the fewer defects you will have, the more confidence you'll have that you're getting the right result. As you have more imprecision, as you have more bias, however, you're getting further away from those lines or rings of the target, which means you're generating more defects, which means you're starting to put more analytical noise around all of your results. And then in the upper right quadrant, really you're confusing clinicians. You're making things very uncertain. You're not going to be able to really confirm a diagnosis, much more likely that you're just going to confuse the clinician. So having introduced that tool, we're going to walk through some examples. We're going to start with an instrument. It's a new instrument. I'm not going to call out its name, but you can see by this, it's got 8 assays and multiple levels that we've measured, and almost all of them are below 2 sigma. In fact, most of them are really off the chart. I tucked them at the edge of the graph because I just needed to keep them within visual range. But if I let those points go, they'll probably drift off the right of your screen. And this is, one of the things that we have to worry about as we see more and more new entries and new diagnostic companies coming to market with cheap hematology instruments. They may not be delivering good quality. Whenever it's too inexpensive, you have to worry they compromise their quality, and that's how they made a cheap instrument. Here's another instrument. This is just 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 maybe, different methods, and a majority of them, again, are below 2 sigma. There's a couple in the bullseye, but most of them are pretty poor in performance and really are tucked at the edge of the graph. Some of these are not are at the top edge of the graph, which means actually the problem may not be the imprecision, but really it's the bias. And now here's a look at the Abbott Alinity, and this has 15 different assays, 3 levels each. There's 45 levels of performance, and you will see that 2/3, you see the light blue, the dark blue, and the green, that's more than 66% of the performance, are at 4 and 5 and 6 sigma. So you can see there's some big variability out in the marketplace. Hematology instruments are not commodities. We cannot take the quality for granted. We really have to assess them and make sure they're delivering the level of quality that is necessary. Now, the next tool we want to look at is the tool that changes how we do QC. Because it's useful to have these method decision charts and see what's in the bullseye and what isn't, but much more useful would be to know, what do you do with the information? If I tell you you have a 6 sigma method on your hematology instrument, do you know what to do for QC? Do you continue using all the Westgard rules? Do you continue running QC at a high frequency, or can you change those things? And one of the simplest tools that we've made available in the last few years is what we call Westgard Sigma rules. It takes the traditional Westgard rules, but it adds that 6 sigma component. And what you can see on this flow chart, it's the traditional Westgard rules. They've been slightly updated, but if you look a little bit below the red box, you'll see the indications of different sigmas. And then there's some blue vertical lines that are dividing the Westgard rules into different sections. So at 6 sigma, you may see there's a blue line that basically cuts off the Westgard rules into just one rule, the 1,3S rule. Then at 5 sigma, you'll see there are 3 rules. 3 rules are necessary for a method of 5 sigma. At 4 sigma, you need 4 Westgard rules. At 3 sigma, you need all the Westgard rules. So as your sigma gets lower, you need more Westgard rules. And below 3 sigma, remember 3 sigma being the minimum level of quality that we think is appropriate, below 3 sigma, the Westgard rules can't help you. You will need all the Westgard rules, but you will also need to add non-statistical QC. You'll need to do much more additional techniques, maybe Bull's algorithm, maybe more frequent monitoring or more frequent calibration, something to do that to help keep that method under proper monitoring and keep it well observed. And here's a table version of that, where we've listed out our sigmas and the control rules that are necessary and the number of controls. And then on the very right column, we're looking at one of our instrument examples, and it's telling us how much of the performance that we saw in the previous graph was located in the particular sigma zones. And most striking, 72% of this laboratory instrument's performance is below 3 sigma. So that means this lab needs to use all the Westgard rules on most, nearly 3/4 of the testing. It needs to use more controls themselves, not just the usual 2 or 3, but probably more like 6, or which, if you're not able to afford running that on a single run, you have to start looking across multiple runs. When we look at the Alinity, we can see that actually a majority of that performance is at 5 and 6 sigma, and that's going to mean we reduce the number of Westgard rules necessary up for almost 40% of the performance. We don't need the Westgard rules at all, and we can get away with a minimum number of controls. In fact, it's one area where we could consider going down to 2 controls rather than 3 levels of controls, because that 3 levels, that may be a tradition, but statistically or mathematically, it's not necessary for a 6 sigma test. Now, what we've looked at in our example so far is changing the rules and the number of controls being run, but now we'd like to think about changing the frequency, changing how often we have to run QC. And this has been a question that has we've been grappling and struggling with QC frequency since we started running QC in laboratories. So it's not a new question, it's something we've always had, but we've had a lot of rules of thumb. The first rule of thumb being we base our QC frequency on the rotational speed of the planet, so we're doing it once a day or once every 24 hours. Sometimes it's more frequent. We might be doing it 2 or 3 times a day, once every 8 hours. These are not scientific choices. They're simply rules of thumb. And in the last 4 years, we adopted in the US something called IQCP, which justifies an even stranger practice, which is to reduce your QC to once a month. You're basing your QC frequency on the lunar calendar. None of this seems to be related at all to the patient. The patient's health state doesn't have to have anything to do with the phase of the moon, nor does it have anything to do with how fast our planet is turning. We really would like a patient-based QC frequency, and that comes from adopting a much more rigorous mathematical approach. The mathematical approach that helps us determine QC frequency comes from Kurt Parvin in a paper that was published more than 10 years ago. It's often called the max enough model, with that max enough really standing for the maximum number of expected final unacceptable patient results. It's calculating how many results could be at risk of being wrong for the patient if we have an error that we haven't detected with our QC. And it creates a bunch of risk curves. And these risk curves are a little exotic. You've probably never seen them before, but we'll just take a quick look at them. Along the x-axis is the size of the error. Along the y-axis is the number of patients who are going to be at risk of getting a wrong result. And these risk curves all start at 0 because if we have no analytical error, there are no patients at risk. I think we can all agree about that. But once a little bit of error starts to creep into our methods, the first thing we'll discover is small, tiny errors are not really well detected by our QC rules. Our QC rules can't pick up small errors. So if there's a small error, our QC rule can't pick it up, so that error is more likely to impact patients, so now we have patients who are at risk. So our risk curves are going to start going up. And they will keep going up until the size of the error reaches a certain point, certain size of error that is finally detectable. And our QC rules really start to kick in. the error is big enough, we can start detecting and catching that error. And then that's when the risk curves start to go down again. Because as the error gets bigger than that, the bigger it gets, the easier it is for our QC rule to detect it and go off. And then therefore there are fewer patients at risk because we detected the error, the result wasn't released, fewer patients are at risk. And for very large errors, our QC rules catch them right away, and there's never any risk to patients. So the risk curves go back down to zero again. And the reason why we have different risk curves is we have different QC rules that we're using. If we have Westgard rules and we're using 4 control measurements, that's actually the solid line that you see on this particular graph. If we have Westgard rules but we're using 2 controls, then that's the dashed line. And you see with more controls being run, we have a smaller maximum risk. We have less than 1 patient. That max enough is less than 1. That means there's less than 1 patient who is at risk of getting a wrong result. On the dashed line, our maximum risk is close to 3 patients. That is, there may be at the maximum amount of risk with using this set of rules is that up to 3 patients may be hit with a medical error that we have if we don't detect the analytical error that's happening. And the thing about knowing these peak points of the graph, the maximum risk, is that if we do know that, we can figure out also ways to change those variables so we can minimize that maximum risk. And typically the goal is to try and get the maximum risk down to 1 or less than 1 patient out of any particular run. In the last few years, some papers have come out that have converted these risk curves and the mathematical approach into a simple visual tool. So rather than make you learn how to calculate the max enough and plot your own risk curve, what we've done is sort of transformed that so that you're going to, like the method decision chart, you're going to have a simple visual assessment tool. And that visual assessment tool we call the Six Sigma QC Frequency Nomogram. And here you don't need to know max enough at all. Along the x-axis, you need to know your sigma metric. Along the y-axis, that's actually the number of patients that can go in between your QC events. And the diagonal lines represent the different QC rules that you might be using. Are you using multi-rule or Westgard rules with certain numbers of controls, or are you using a set of single control limits? And if you knew the sigma metric, which we've already explored is not very hard to determine, you figure out that sigma, you look up and see where it intersects the QC rule that you're using, and then from that point you go all the way over to the y-axis, and that'll tell you how many patients you can allow to pass before you have to run QC again. And this is called a nomogram because it's a logarithmic distribution. The numbers get higher and higher very quickly at the top end of the graph. And probably the most interesting things you want to notice is that at 6 sigma, we're off the chart. At 6 sigma, the intersection of any of those QC lines is going to happen more than 500 patients between our QC runs. In fact, it's probably going to be at least 1,000. So that's the good news is if we have 6 sigma, we'll be able to reduce not only our QC rules and our numbers of controls, but we'll reduce our QC frequency. The other bit of news is what happens at the other end of this graph, at the lower left corner, and that's when you have assays below 3 sigma, and you can quickly see that if we have a below 3 sigma assay, we're going to be running QC quite frequently. A 3 sigma assay running Westgard rules with 4 controls is going to have to run those 4 controls every 10 patient samples. That's very frequent, very, very frequent. And we can put that into a summary table again with 6 sigma telling us conservatively we can reduce our QC frequency to once per 1,000 patients, whereas below 3 sigma we want to be looking at once per 10 patients. If you're even lower, if you're at 2 sigma or 1 sigma, effectively it becomes as ridiculous as you need to run a QC for every patient. And of course, that's absurd. That means essentially we don't have enough resource to properly QC that method. If it's a very low sigma, not only can we not monitor it well enough with Westgard rules, but we can't afford to run as many controls as necessary. We've also summarized that in the Westgard sigma rules. I didn't take note of it in the earlier presentation of it, but you see in the red box at the bottom, those are the suggested run sizes for the different sigma zones. So this particular Westgard sigma rules formulation, that particular chart you can download for free off the Westgard website, and it can help you figure out your sigma metric and figure out your Westgard rules and figure out how many controls to run and how often you need to run those controls. If we now look at our two examples that we went through for one of our methods, again, which we didn't want to call out, but for this instrument X, they have to be running all the Westgard rules. They should be thinking about a dozen controls and be running once every 10 patients, if not more frequently. That effectively you're running more controls than you're running patients. That's an instrument that is just not appropriate for the lab. It's a budget buster. It's not good for patients. For the Alinity, we'll see that a majority of the performance, we will not have to use all the Westgard rules. There's no perfect instrument. There are some areas, some of the differential counts are particularly challenging, and those will need more Westgard rules and possibly more controls. But if you look at the overall performance and if you have to synchronize how you're going to do QC, you're probably going to do it on a reduced frequency with reduced rules and therefore reduced expenses. So let's wrap this up. We've gone over a lot of different tools for QC and benchmarking and performance assessment. I want to assure you that every different tool that I've introduced in this very short time, you can download for free off the Westgard website. And then there are more examples of how to use those tools and more examples of different instruments out there so you can figure out what's out there and how you would apply these tools in a hematology scenario. One of the most important lessons I want to impart to you is that a lot of common QC practices in hematology are counterproductive. They're wasteful. They're probably frustrating you, and we should abandon them. And by knowing your sigma metric, that'll help you figure out how to readjust the way you're doing QC. That'll help reduce the number of outliers, reduce the number of repeats and other bad practices that you're doing. Also, if you're using the manufacturer's range and the manufacturer's controls, those are going to make it very difficult to do QC the right way. If you use a manufacturer's SD, that's going to be big. It's going to lower your sigma metric, which is going to tell you to use more rules and run QC more often. Whereas if you do your own SD, that will be smaller. It'll give you the more appropriate assessment of your quality, and you'll be able to use, hopefully, fewer rules and fewer controls. So when we combine the Six Sigma approach with the Westgard rules, with the QC frequency tools, we can make sure we're doing the right QC with the right controls at the right frequency, and all of that is helping us support the right patient care and the right results going to the patient. And with that, I want to thank you for listening in, for accommodating me and looking at these different tools. And now I would like to open this up to your questions. And if you are shy, I also want you to see at the bottom of this particular slide, my boss mandates that I put my email address at the end of every presentation. So you have another way to send me questions or any complaints or comments as well. And again, thank you, and I look forward to hearing your questions now.
Thank you, Sten, for your informative presentation. We will now start the live Q&A portion of the webinar. Now, if you have a question you would like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many questions as we have time for. Okay, Sten, let's get started. Let's start with this question. What is DPM?
Okay, that's a great question, Christy, and let me just pull up the slide that's most relevant. When we talk about Six Sigma, there's 1, 2, 3, 4, 5, 6 sigma, but underneath each category of sigma is a number of defects per million. So Six Sigma works on a scale of 1 million opportunities. So you run a process 1 million times, you report, you run 1 million different patient samples. How many of those are going to have defective results or false positives or false negatives? And the DPM, defects per million, is what equates the number of defects to the sigma level. At 6 sigma, it's less than 4 defects per million. So the DPM is 3.4, actually. And then at 3 sigma, it's about 67,000 defects per million. Sometimes you'll also hear it called DPMO, which is defects per million opportunities.
Thank you, Sten. Now we have some great questions coming in, and I know we're coming up at the top of the hour, so we're going to try to fit as many questions in as we can. Let's go with our next question. We have Abbott analyzers, Selden Ruby, and we use controls provided for Abbott, but these controls are manufactured for Streck. Do you consider this controls as a third-party control?
That's a good question, and it brings to mind the difference between a bundled control and a manufacturer's control. So as we noted earlier, the guidelines and the regulations are encouraging labs to use independent or third-party controls. A manufacturer's control, the control itself has been somehow affected by the manufacturer itself. Whereas a control that is independent, the manufacturer hasn't had a chance to make any adjustments. So if you're using Streck controls and they're bundled with your instrument, whatever instrument that happens to be, that should maintain its independence. They're just bundled together. They're not actually aligned by the manufacturer. And of course, again, just to reiterate, the reason manufacturer controls are not encouraged is there's been too much evidence that the manufacturer will try to widen the ranges, or they'll adjust the mean, or in some ways they're going to manipulate how the control is run so that the lab is not able to detect all the errors that are occurring.
And in a single CBC run, there are several parameters. What if sigma varies per parameter? And how should we collectively rank sigma in a single CBC?
Another great question. I think if anything you get out of today's presentation is there is a high degree of variability, not only from instrument to instrument, but from test to test on the sigma metric. And it's particularly challenging for hematology because you make all the same measurements at the same time, but you will find for some counts, for some parameters, for some indexes, the sigma is not the same. So across, basically any instrument, there is no one sigma, or I should say there's no single sigma metric that covers the whole instrument or all of the different tests. So you will have some areas where the parameters are at 6 sigma and other parameters are at 3 sigma. And that does mean there's a challenge about what rules you're going to apply, how many controls you're going to run, and even now that we have the QC frequency guidance, how often you're going to run QC. And of course, it's impossible to change the frequency of QC on an index. You can't be running on your hemoglobin, you're running once per 1,000, but then on your MCV, you're running once per 500. You can't vary the number of controls that way. So effectively, you have to come up with a compromise that covers all of the different parameters. You might decide I'm going to run your QC and set your rules just based on the worst case scenario, or you might decide maybe I'll do it on the best case scenario or somewhere in the middle, or what we encourage is define what are the critical decision levels, what's the medical decision level where diagnoses are being made or patient outcomes are most impactful, and fix your sigma around that. And then also, I would say you're going to go with a majority sense of, do I have most of my assays at 6 sigma? I have a couple assays at 4, a couple at 3. Maybe I have one parameter that's below 2 sigma. I'm probably going to design for the majority of the assays, and then for the ones that are in the minority, if I have 1 or 2 assays that are not very good, I'll try and take additional actions for them. They may be something that I do in addition to the statistical QC, so that I might use more rules, but I might not be able to afford to run more controls or to run those controls more frequently. And on the outside of statistical QC, perhaps using the monitoring of patient values, I'm going to be doing more scrutiny of those particular parameters.
Thank you, Sten. Now let's come over to a question from Tyler. Can the lab use a different Westgard multi-rule definition? For example, S31S or 3-to-1S as a warn rule instead of a systematic error run reject rule?
Well, that's a good question. And let's back up and just acknowledge that while everyone believes there's one set of Westgard rules, and the 1981 paper made a particular set of rules famous, and many people take that as a standard, that is not carved in stone. The Westgard multi-rule approach is meant to be flexible. So there are combinations that are good for when you're running 2 levels of control. There are combinations that are more appropriate when you're running 3 levels of control. And then one of the points of this presentation was to use the sigma to help you limit and reduce the number of Westgard rules that you're using. So there's a lot of flexibility that is inherent in how you're supposed to use Westgard rules and sigma metrics. Now, using the 1-3S rule or the 3-1S as a warning rule, that's perfectly acceptable. You can take any rule that you want and turn it into a warning rule. Most of what our sigma metrics are doing for us are telling us what rules must be the rejection rules, and then any other rule beyond that, if you want to turn it into a warning rule, that's perfectly fine. And use your professional judgment. If you want to see that and be alerted to it, that's fine. Okay, because a warning rule is not a rejection, and for most of your warnings, you're going to end up clearing it anyways. So that's whether you turn a rule into a warning rule is really more about your own time management. You just want to make sure you're not picking warning rules that go off so often that they're really just a distraction.
Thank you, Sten. Now, this question has a few parts. From a pragmatic point of view, how do we determine QC frequency? When the QC material covers all reportables, there is a variable range of quality in each channel, which means a decision is needed. Do we set QC frequency to the bad baso number channel or the stable RBC channel? With a wide range of total error for something like the monos, does it really matter?
That's great, and I think that is the new challenge. You know, now that we have the science of determining QC frequency, now we have to match the mathematics that we can get for QC frequency with the practical reality of how tests are run. And certainly for something like the monocytes and the baso channel, the quality on some of those differential counts for a lot of different manufacturers is not as high as what you'd see on the RBC channel. So this is new, and actually this is, I suppose it's an opportunity for labs to really apply and publish their results, because the science is only about 3 years old, and we're still trying to find laboratories to implement this and see what they find as the most useful, the most practical, the most effective way to implement these QC frequency policies. So it's one area where I agree that there's a challenge, and I think the math provides us with one answer, but the more interesting answer is going to come in the field from laboratories like yourself to see what ends up being the best combination or the best consensus of the different capabilities of the assay.
Thank you, Sten. And thank you, Max, for that question. Let's come over to a question from Christian. Can we use the manufacturer control just to obtain our CV and SD and an external control to obtain our bias?
That's an interesting question. Typically, when we talk about how we obtain CV and bias, we typically obtain that through two different sources. So we would be running some kind of controls to determine our imprecision, and then we have some kind of external quality assessment or proficiency testing that may help us determine our bias. But if we were going to be using a control to determine our bias, so for instance, we have a control and we have the peer group mean or the labeled mean, if I was going to be using that to determine my bias, I would also want to use the imprecision from that control in any assessment of sigma metric. I wouldn't want to use the imprecision of the manufacturer control and then the bias of a third-party control to come up with a sigma metric. I feel like, again, the manufacturer's control may be over-optimized, so that imprecision will come in being a little too low. The imprecision from the external control, or maybe we shouldn't call it the external control, the imprecision coming from the third party or the independent control, that's considered best practice as a way to determine your real imprecision.
Thank you, Sten. Now I know we're getting close to time, but let's try to squeeze in a few more. So let's go, here we go. Many sites I assist receive one hematology sample per month, or 12 per year, for their EQA-PT program. What recommendations do you have to best utilize this external QC approach, which can complement their internal QC management program?
All right, so what we would probably want to do in this case is use multiple samples and over multiple months to determine the bias. We wouldn't want to peg too much importance on just the one single once per month measurement. If we would calculate something like a confidence interval around that, we would not be very happy. But as we get a new data point, if we merge that information with the previous 3, 6, or 12 samples that came in over the past year, we could get a little more confidence about what is the bias that we're seeing. So we could get the individual bias percentages and average them all together. Maybe that's not the most ideal way to determine your bias, but it is giving you a long-term assessment and an overall assessment of the bias that you're mentioning, that you're trying to determine.
Thank you, Sten. Now, how often do we have to measure our Six Sigma?
Measuring Six Sigma, we find when we've actually talked with labs that do Six Sigma, they're looking maybe at once every 3 months or once a month. And the only reason that they're doing it once a month that frequently is typically most labs are doing a QC review at the end of a month. And at the same time you're doing a QC review, you have all the same information that is going to feed into your Sigma metric. So if you're looking at the QC events, you have the data. You can also look at an update of the Sigma metric. I do want to calm everyone. Just because you're looking at a Sigma metric every month doesn't mean that any change will cause you to change how you're doing QC or how often you're going to run QC. We have examples on the website where labs have been running instruments for 8-9 years and monitoring Six Sigma metrics for that entire period. And for some tests, they haven't changed their Sigma metric effectively for that whole period. That is, it was Six Sigma 9 years ago, it's Six Sigma today, it's been Six Sigma throughout those 9 years. It may have fluctuated slightly, but it stayed above Six Sigma, and that meant there were no QC modifications that had to be made for that entire period.
Okay, let's go with this next question. What is the laboratory to do when they have tests, for example, total CO2, with terrible Sigma metric performance? There isn't an option to change chemistry instruments, so what is a lab to do?
That's a great question, and that is a challenge that labs face in chemistry. They can face it in hematology. They can face it just about anywhere. There are no perfect instruments. There's always the possibility you're going to get a bad assay on a big menu. I will say specifically to CO2, that is a challenge of an assay. It's very hard for an automated instrument to get a good CO2 method. And typically what we recommend is sometimes you can look at, if it's an open system, you can see if you get a different reagent and improve the performance. But let's take the broader idea of, I have an assay, it's not great, what am I going to do with that? If switching is not an option, if you've tried ways to improve the imprecision, you've tried ways to reduce the bias, and you still have a low Sigma metric, then one of the things you can do is employ what's called a reference change value, RCV. Sometimes it's called a critical difference. The person who has popularized it the most was Callum Fraser. You can find a lot of details about this on our website and in the scientific literature. But essentially, it helps you adjust the clinician's expectations about how to handle those results. So if you have a low-performing assay, you'll be telling the clinician, you need to wait for a big change before you think something has happened with a patient. You can actually flag between serial results. You can say the difference between the last result on this patient and this result is not big enough for you to think there's a clinical change. It's just noise. It's just the difference from day to day. So don't make a medical decision on that particular result. So we can sort of couch each result in the context of its quality. For a Six Sigma assay, when you report that out, you can let the clinician know if there's a change here and it looks like it's clinically significant, we're very confident that we're going to be wrong about that less than 4 times out of a million reportable results. So if you see a change, it's probably a change in the patient. A low sigma, you start cautioning the clinician, don't make a decision yet, let the change get bigger, do more monitoring.
Now, Sten, is it correct that these general principles that you've described this morning also apply to general chemistry and immunoassays?
Yeah, obviously the Westgard rules are most well known and applied in chemistry. We have, if you look at our website, a majority of the examples that we show are on chemistry, but if it has a quantitative result, then that test can probably be applied with sigmametrics. So the sigmametric equation itself doesn't care if it's from chemistry or immunoassay or coag or infectious disease or hematology. As long as those numbers are coming in and they have the right distribution, we can apply sigmametrics. There's a little bit of individual details for each kind of test. Hematology is different because of the short shelf life of hematology controls and some of the indexes, but there are adjustments that we can make on how we apply sigmametrics in those scenarios.
Thank you, Sten. Now, we have so many great questions coming in. We could be talking and answering questions for at least another hour or so, but let's go ahead and wrap with this final question. I just want to remind all of our audience members that those questions that you did submit today that we don't have time to answer, and all those questions that you are able to submit during the on-demand period, they will be addressed via the email address you provided at the time of registration. So, Sten, let's go with this one final question. How should my QC approach change with the recent waived instrumentation for CBC, for example, full blood count, and FBC analysis soon to be on the IVD market?
Okay, and just before I answer that question, I will say at the Westgard websites, we'll try and put together as many of the questions that have been submitted and put answers to them. And so not only will we possibly respond to your email, but we'll try and put something online on one of our websites that is accessible for everyone. So look for a forthcoming Q&A set article on the Westgard website. Now, getting back to the specific question, there's a regulatory answer to this question, and then there is a best practice answer to this question. So with waived instruments, theoretically, the FDA has made a determination that no harm can come from the use of these results, and therefore the only thing that the user has to do is follow the manufacturer's directions. And the manufacturer may just say, put your limits out at this set, put your limits here, X and Y, and run 3 controls and 3 external controls, maybe once a week, once a month, or something like that, and you will be in compliance, but you may not be doing best practice at all. So regardless of the status of the instrument, whether it's waived, non-waived, whether it's moderately or high complex, we encourage the same best practice, which is determine your own standard deviation, determine your own mean, try and do some regular checking against some external source. You want to do proficiency testing and external quality assessment. Use that imprecision, use that bias to help you determine a sigmametric. If it turns out, yes, I have a 6 sigma method, and it tells me I could reduce my QC frequency to once per several thousand patient results, if that happens to go along with the manufacturer's recommendations, that's great. If you turns out you have an instrument that's waived, but the sigmametrics are really, really low, I would follow the sigmametrics and say, I need to do more Westgard rules, I need to run more controls than what the manufacturer is recommending. Because it's better to be helping your patients with the appropriate level of quality than just maintaining the compliance and surviving an inspection. And with that, I do want to, again, thank you all for attending. Thank you for submitting such good questions. Stay tuned for the answers to those questions. And stay tuned because there will be more articles about hematology QC coming forth in the next year.
Thank you, Sten. And would you remind our audience what that website is?
Oh, sorry. It's westgard.com. And of course, my own email address is westgard@westgard.com.
Excellent. Thank you again, Sten, for your time today and for your important contribution to laboratory quality control. We'd also like to thank LabRoots and our sponsor, Abbott Laboratories, for underwriting today's educational webcast. One last thank you to our audience for joining us today and for their interesting questions. Again, those questions we were not able to answer today, and any of those that are submitted during the on-demand period will be addressed via the email address you provided at the time of registration. And as Sten mentioned, he will be doing a little Q&A listing on his website, and that website is westgard.com. Now, this webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now, and we hope to see you again soon. Have a great day.